What if I told you that one biological event changes nearly every organ system in your body? Your brain, my gosh, your heart, your bones, your muscles, your metabolism, your sleep, even your urinary tract and your sexual health. Now, what if I told you that this event happens to roughly half of the world's population? And despite affecting billions of women throughout history, it remains one of the most misunderstood transitions of all medicine. For decades, women have been told that symptoms of menopause are simply just something they have to deal with. You're going to have to just deal with it. You're tired. That's menopause. You're gaining weight. That's menopause. You can't sleep. Oh, that's menopause. Sex hurts. That's menopause. You don't recognize your own body anymore. My gosh. Don't worry about it. It's just menopause. It's a normal. Well, yes and no. Menopause is absolutely normal, right? It's a normal biological transition, but unnecessary suffering is not. Okay. So today we're going to separate science from speculation. We're going to discuss what actually happens inside your body during peri and post menopause, right? So we'll explore the latest evidence surrounding hormone replacement therapy, also vaginal estrogen. We're going to talk about cardiovascular health, muscle preservation. I know we talk about that a lot, but it's important. We're going to talk about brain aging, sprint interval training. It seems like it's weird to be thrown in there, but you'll get it when we get there, right? And then we'll talk about in today's peptide spotlight, we'll take a deep dive into PT141, a really crazy awesome therapy that works in a completely different way than most people believe or even realize. Okay, so ladies, if you've entered menopause or you're approaching menopause or love somebody who is, this episode is for you. And guys, don't tune out. All right. I know we're going to talk about a lot of weird stuff that you're not familiar with or maybe you're not interested in, but think about it, because if your wife or your partner or your sister or your niece or your mother or, your daughter experiences, menopause one day, and statistically they will, okay, understanding what they're going through may be one of the greatest gifts that you can offer them. All right. So let's get started. Welcome back, everybody, to another episode of the Longevity Game podcast. I'm your host, Michael Ward, nurse practitioner and founder of Next Level TRT. And as always, I want to thank every single one of you guys for spending your part of the day with me. This is going to be quite a robust episode because I pulled together a lot of information that I feel is very, very pertinent. And I didn't want to separate it out into different podcast episodes. I feel like it all goes together cohesively. And I believe that it's something that we should cover all together. And so it's going to be a little bit of a longer episode today, but I'll try to get through it as fast as I can, but do so in a way that is informative but entertaining. And so I hope you guys love it. I hope you enjoy it. I hope it brings value. If you're new to the podcast, welcome. Here at the Longevity Game, our goal is it's not simply to help you live longer, right? It's to help you build more healthy years, right? And so the years where you can still hike with the grandchildren, you know what I mean? You can still travel with your spouse or your partner, right? You can pick up your grandkids without hurting your back, right? Stay independent, stay maybe mentally sharp, and continue pursuing those things, those hobbies that you love for as long as you can, right? Because longevity without quality isn't really longevity, right? That's what we mean about whenever we talk about health span versus lifespan. And so that's the game we're here to play, guys. So before we dive into today's topic, I want to thank all of you guys who continue to follow the podcast and share the podcast with your friends and family. It really, really means a lot to me. The audiences the audience continues to grow week after week, and that's because of you guys. And so I really appreciate it. If you've been enjoying these episodes, I'd really, really appreciate it if you could leave us a review on Spotify or on Apple Podcasts. We're also on iHeartRadio and we're on Prime, Amazon. They have podcasts on there now. I don't know if you know that. But those reviews really help more people discover the podcast, right? And ultimately, they help us spread evidence-based and evidence-informed information that kind of cuts through all that BS out there, surrounding hormones and peptides and longevity. right? So anyway, let's jump in. Let's jump in today's longevity headlines. Now I've got 3 headlines that all caught my attention this week, and it's funny how these things come across. I get emails and because of what I do, I get tons of stuff in my social media feed that really pique my interest, and so when I see something that piques my interest, I like to take a deep dive into that and really see what's going on behind the scenes because there is a lot of misinformation out there in social media land. So anyway, headline number 1 is the conversation around menopausal hormone therapy and how it continues to change. So this is really a great topic for me. I like this stuff. You probably noticed something over the past couple of years. More physicians and more researchers, even more professional organizations, they're really starting to revisit the conversation around menopausal hormone therapy. And so, for years, lots of years, many women, understandably or hesitant after the Women's Health Initiative study made headlines in the 2000s, the messaging that reached the public was often far more absolute than the science was, right? And so today our understanding is way different. It's much more nuanced. And we recognize that, not all hormone therapy is the same. The type of estrogen matters. The route of administration matters. Whether progesterone is needed or started, that matters. The number of years since menopause started matters. And perhaps most importantly, the individual woman sitting in front of you as a healthcare provider, if you're listening, matters, right? And so medicine's really been moving away from blanket recommendations, which I think is cool. And it's been moving toward more individualized care, which is certainly where it needs to be. I'll explain why a little later in the episode. So the second headline was that muscle continues to dominate the longevity conversation. And so we always talk about at least one at one point in every episode I'm talking about muscle, I believe. And that's important, not because I'm a bodybuilder, but because I think everybody needs to look at building muscle as something that is supremely important in longevity. The science keeps pointing us back to the same conclusion. Healthy muscle is one of the greatest predictors of healthy aging, you know? And so, anyway, this week I came across this additional research looking at lower extremity strength and long-term cognitive health, right? And so we're going to unpack that study a little later. I think it has profound implications, particularly for women after menopause, right? And so that's why I'm going to circle back to this later. This particular topic is super important in women after menopause. So, spoiler alert, leg day is, it may be a lot more important than just protecting your knees. Okay, just trust me. It's going to be good. It also could be possibly, preserving your brain function, so, and we'll get into that, but it's incredibly fascinating. The third headline involves sprint interval training. It's exercises medicine, even in small doses. That was the headline. Now, look, don't panic. When people hear the word sprint, they immediately picture like Olympic athletes, sprinting down a 400-meter race course. That's not what we're talking about. So researchers have found, or they continue finding, that relatively short bursts of appropriately prescribed high-intensity effort can produce just remarkable improvements in cardiovascular health and even among individuals who aren't really elite athletes. And so one study caught my attention that looked like it changes the way your heart looks, like cardiac remodeling. And it was fascinating. It's fascinating. We'll get into it, but it explains how how efficiently if it pumps blood, how stroke volume improves, and how surprisingly little exercise that is required to achieve those positive adaptations. So it's really cool. We'll dive into that a little later because it is incredibly encouraging for people who tell me, Mike, I just don't have enough time to work out. Well, you might not need as much time as you think. And that brings us to today's huge main topic. I have to tell you, I've been looking forward to recording this episode for quite some time because although menopause affects like millions of women every single year, I honestly don't think that we talk about it enough, you know, or maybe we just don't talk about it as accurately as we need. We don't talk about it correctly, right? I've had countless women sit across from me in my clinic. Some are in their mid 40s, some are in their 50s, and some are well into their 60s, right? And many of them say the exact same thing. I just don't feel like myself anymore, or they'll say something like this, I don't recognize my body anymore, or I feel like one day I woke up and everything changed. And here's what I always tell them, menopause is not your body betraying you. It's not. It's just your biology is changing, right? There's a difference. For nearly 40 years, your body has operated in one hormonal environment. Then gradually, and sometimes seemingly overnight, that environment just changes completely. So imagine this. Imagine that you've been driving like a high performance car, for your entire life. Okay. And one night while you're asleep, somebody sneaks into the garage and they quietly replace the engine with an entirely different engine. Okay. The car looks exactly the same. The steering wheel is the same. The seats are the same. The paint is the same. The car is the same. And from the outside, nothing appears different. But under the hood, everything has changed, right? Now imagine trying to drive that car, right? I mean, you try to drive it like you've always driven it, you'd probably get pretty frustrated. You might even think that something's broken. But the truth is, nothing's broken. Your operating system has changed. That's it. Your body now responds differently to exercise. It responds maybe differently to stress, differently to sleep and nutrition, and maybe even differently to hormones, right? The rules have changed. Okay. And once you understand those new rules, man, you can learn to thrive in this new chapter just as powerfully as you have in the past, right? Now, I want everybody or every woman listening today to hear me really clearly here. Menopause is not the end of vitality. All right. It's not the end of femininity, right? It's not the end of intimacy. It's not the end of athleticism. And, it's not the end of your confidence. It's certainly not the end of your story. It's simply the beginning of a new biological chapter. And just like every chapter before it, it just requires a different strategy. All right. Stay optimistic. You're going to be just fine. So today, let's learn that strategy together, I guess. So, because I think once you understand what's actually happening beneath the hood, everything is going to start to make a whole lot more sense, right? And I think that you're going to discover that your body isn't working against you. It's just simply asking you to work with it in a new way. Okay. So let's answer the question that almost every woman eventually asks. What is happening inside my body during menopause? I hope you've asked that question. Because the answer is far more fascinating than most people realize. Okay. Stay with me here. I think we should start with this. So what exactly is menopause? Let's start with a simple definition. This is super easy. Menopause is officially diagnosed after 1 year of no menstrual cycle, right? No period. And that's it. That's that simple. After you've had 1 year, no period, you are officially in menopause. It's like a retrospective diagnosis, right? So you don't wake up one morning and then become menopausal, right? That's not how it works. The transition into menopause actually begins years earlier during a phase called pre-menopause. And so well, I guess you could call it perimenopause. It's perimenopause. We'll call it perimenopause. Think of perimenopause as the body's gradual transition period. So you do have premenopause. I think it's the same. Premenopause, perimenopause, it's, I guess, depending on the years, right? 3 to 4 years before menopause is perimenopause. And so the ovaries begin producing hormones less consistently during that time, right? Ovulation becomes really, really unpredictable. And estrogen doesn't simply decline in a straight line, right? It often fluctuates, right? So from month to month, you can feel like a completely different person, right? That hormonal variability, it helps explain why some symptoms can seem unpredictable. One month, a woman may feel relatively normal. The next, she has sleep disruptions. She has hot flashes, mood changes, heavier menstrual bleeding, stuff like that. And eventually, ovarian estrogen production, it settles in a much lower, more like a stable level, right? And then menopause is reached. And so menopause isn't one day, it's a journey. Okay. So I think here we haven't hit the fascinating part yet. Okay. Here's where things become fascinating, right? I think that most people think estrogen exists just simply to regulate menstrual cycles or fertility, right? Well, that's understandable because that's probably what you learned in school, or that may have been what you were told by your mom, but there's really estrogen receptors throughout your entire body, right? They're found in the brain and in the heart. They're found in blood vessels, in your bones and skeletal muscle, in your skin, in connective tissue, even in the bladder, the urethra, and the vagina, like the pelvic floor, even within your immune system. It's everywhere. The estrogen receptors are throughout your whole body, and they can affect all kinds of things, not just fertility, not just you know, your menstrual cycle, right? It has been just doing tons of things in your body for decades, and you may not have even known it. So now imagine one of the primary voices in those conversations suddenly becoming much quieter, right? The conversations don't stop, but they certainly change, right? And that is why menopause affects so much more than reproduction. So let's start with which organs that are affected, right? Let's start with, I like to start with an organ that probably surprises most people, the brain. All right. Your brain is affected by estrogen and its decline. And so one of the most common complaints that I get in the clinic is this: Michael, I feel like my brain just isn't working the way it used to. You know, some some people describe it as brain fog, you know. Others, they say that they struggle to find words when they're talking. And some people even tell me that they lose their train of thought in the middle of a sentence. And I've done that a couple times, right? And that I can recall, and it's really embarrassing. So I can understand how frustrating that could be. And because of it, some women think that they may be developing dementia. I mean, and I understandably. Fortunately, in the overwhelming majority of cases, they're not, right? Statistically, you're safe, right? Instead, there's several things that are just kind of converging all at one time. So if you think about it, estrogen interacts with neurotransmitter systems involved in mood, involved in your attention, in your memory, and even your executive function. Okay. And so it also influences how efficiently the brain uses glucose, its primary fuel, right? And on top of that, menopause frequently disrupts sleep. And many of you know what I'm talking about. And just poor sleep alone can have profound effects on concentration and processing speed and just even your memory. And so think about think about this. And this compounds over time, right? Think about what happens just after one night of bad sleep. Now imagine months or years of fragmented sleep because you're waking up, in a pool of sweat, you know, from hot flashes, you know what I mean? Anybody's cognition would suffer. Okay. Here's something that I like to remind patients. Sometimes what feels like a memory problem is really a sleep problem. You know, sleep is, there's so many things that happen while you're asleep, and if you're missing out on the sleep, you're missing out on those things. If you think about it, sleep is where your brain consolidates memories, right? It's where waste products are cleared. It's where emotional processing occurs. It's where learning is reinforced. If menopause repeatedly interrupts sleep, man, your brain just simply doesn't have that restorative time that it needs. And so that's just one reason why treating sleep is not just hot flashes. can make a huge difference in how women feel, right? I mean, I constantly ask people, how's your sleep? You know, are you tracking your sleep? It's a good idea if you can track your sleep, like using wearables like Oura Ring. Super impressive what these things can do. And so if you're tracking your sleep, you'll have a better idea of what your sleep looks like, because the time that you spend in bed doesn't necessarily translate to an adequate night's sleep. So let's talk about the heart. All right. So heart disease remains the leading cause of death among men, but also women, right? Excuse me. Yet many people really still think of heart disease as like a men's thing, right? That's a men's risk, heart disease. That's not true. All right. Before menopause, endogenous estrogen estrogen that's produced inside your body, endogenous estrogen, it appears to support healthy vascular function in a variety of ways. Okay. One way is it maintains endothelial function, right? So because estrogen, it supports nitric oxide production, right? Nitric oxide causes vasodilation of your blood vessels, right? And so it also helps favorably affect certain lipid parameters, right? And so as estrogen levels decline, those protective influences, they're gone, right? And so over time, we see increases in LDL, the LDL cholesterol, low density lipoprotein cholesterol. We also see changes in body fat distribution, toward more like around the belly, visceral fat. We also see reduced vascular flexibility because the nitric oxide is not there as abundant, right? And there's a gradual rise in cardiovascular risk because of it. This doesn't mean, guys, that menopause causes heart disease, right? It just means that cardiovascular landscape after menopause, it changes. And so this makes lifestyle factors even more important. Get a sip of water. All right. So this is kind of why I like to tell my patients that menopause isn't the time to become less active, right? It's time to turn it up, right? It's time to become more intentional. The next thing that a decline in estrogen can affect is your metabolism. So one of the questions or frustrations, I guess, that I hear is, Michael, I'm eating the same foods I've always eaten. I'm exercising, nothing's changed. So why am I gaining weight? If you ever said that, you're not imagining it, okay? Because several things are happening simultaneously to cause this, right? First, lean muscle naturally declines as we get older, right? I mean, by a lot. And unless you're really actively working to preserve it, it will decline quite a bit after 40. Also, your resting metabolic rate starts to decline, right? It decreases. And then also, because estrogen influences where fat is stored, many women begin accumulating, like I was saying, more fat around the abdomen rather than the hips and the thighs. And this can happen like 4 years to 5 years even before menopause happens. These changes start happening when you start having these fluctuations in your hormones. Also, sleep disruption. Sleep disruption increases hunger hormones, right? And it reduces satiety signals, right? So, and sleep disruption is a big thing, as we talked about. Energy levels often decline, and this leads to less spontaneous movement throughout the day. So you're not getting that neat non-exercise activity thermogenesis, which really accounts for most of the calorie burn in a 24-hour period, right? And so, taken together, even if the scale doesn't change dramatically, body composition often is changing. And this is kind of where I want to shift the conversation. I think I honestly, I don't care much about what the number is on the scale as I do about what makes up that number. You know, two women can have the exact same weight, right? One can have excellent muscle mass, right? One can have healthy bones. They can have very low visceral body fat, outstanding metabolic health. And the other has maybe significantly less muscle, more visceral fat, right? Lower bone density and greater insulin resistance. But the scale can't tell those stories, right? The scale just says they're both the same weight, but a body composition can. body composition analysis. And that's why I really believe that measuring what your body is made of is often far more informative than simply measuring how much you weigh, right? And this is why I think, that this is why we add body composition scanning at my clinic, Next Level TRT. You know, I think I think it's supremely important to do body composition measurements at least twice a year if you can. And DEXA scan is the gold standard. You can look at bone mineral density using DEXA scan. You can see if your bones are getting more dense if you decide to get on estrogen therapy. You can see if your bones are becoming more brittle if, as you're aging and you're not on hormone replacement therapy. You can see where visceral body fat is being stored. You can see how much skeletal muscle mass you have. I mean, DEXA scans are great. And so I'd highly encourage you if you've never done a DEXA scan, I'd highly encourage you getting into one and checking it out. This may surprise you, but if I had to choose one tissue that predicts healthy aging better than almost any other, you probably know what I'm going to say. It's skeletal muscle, right? I'd choose skeletal muscle. It's not just something that makes you look fit. And I've said this before, muscles make you look damn good, but it's more than aesthetics, right? It's one of the largest endocrine organs in the body. You know that every time you exercise, when you contract muscle, it releases signaling molecules called myokines, right? We've talked about this if you've paid attention to previous episodes. And these molecules, they communicate with each other and they communicate with the brain, the liver, the adipose tissue, right? Bones, and even the immune system. And so, in many ways, muscle acts like a pharmacy, that manufactures beneficial compounds, right, in response to movement. And so, muscle, it also serves the body as a primary reservoir for glucose. I think we talked about that too. As you lose more muscle mass, your body manages glucose and handles glucose differently. So the more muscle mass you have, the less insulin resistance you have because, you have this glucose sink where you store a lot of your glucose right in the muscle. And it's one of the reasons resistance training has effects that extend far beyond just strength, right? So you're not simply building bigger muscles, you're improving your communication between your organs, right? And so I think this is where it becomes really, really fascinating. Researchers have found that, individuals with greater lower extremity strength tend to maintain better cognitive function as they age, And so now I got to be really careful here. That doesn't prove, that stronger legs directly prevent dementia, but science, it really works that way, right? But it does tell us something really important. It tells us that the body ages as an integrated system, you know, and healthy muscles support a healthy metabolism, which we know that. And then a healthy metabolism supports healthy blood vessels, right? And then healthy blood vessels support healthy brains. You see how that everything's connected, you know? So, yes, leg day matters, guys, but perhaps not for the reason that you thought before this conversation. Let's talk about bone. So, one area that I believe that doesn't receive nearly enough attention is bone, right? So, bone isn't just some inert scaffolding that's holding us straight up, it's living tissue, right? Every day, we have specialized cells that are breaking down old bone. Those are called osteoclasts, by the way. And then we have other specialized cells that are building new bone. Those are osteoblasts, right? I think build blasts, right? So that's how you can remember that. And so estrogen helps maintain the balance between those processes, right? And then when estrogen declines, bone resorption begins to outpace bone formation, right? And so over time, bones become more porous and then your fracture risk increases, which can inevitably lead to debility, and it goes downhill from there, right? The challenge is that osteoporosis has been called the silent disease, right? That's because you usually don't feel your bones, becoming weaker, right? The first sign is usually a fracture. This is why appropriate screening is really important. This is also why resistance training, specifically to the bone, is really important. This is also why adequate dietary protein, vitamin D supplements, calcium intake, and individualized medical therapy, that's really important, right? Especially if you're trying to preserve skeletal health, right? These are why DEXA scans are important. All right. And finally, we're going to talk about sexual health. All right. So, a lot of women are very embarrassed to bring this topic up, sex. I wish this wasn't true though. Many women, they have like painful intercourse, and they assume that painful intercourse or vaginal dryness, or loss of lubrication, urinary symptoms, or just changes in sexual desire is something they just have to accept, like it's just part of it and that's it. But, a lot of the times that's what they've been told for a long time, But here's the good news. You don't have to accept that. These symptoms are common, right? You need to be having these conversations. Okay. Common doesn't mean untreatable. All right. Estrogen plays just a super important role in maintaining the thickness and the elasticity and the blood flow, the lubrication, the microbial environment of the vagina, right? Of the vaginal tissues and the lower urinary tract. Super important. And as estrogen declines, those tissues change. And that's why a lot of women begin experiencing discomforts because the estrogen is declining and things are getting, less optimal. The environment, the architecture is changing. Recurrent urinary tract infections are a thing. Urinary urgency or the feeling like you have to pee a lot, right? Or pain with intimacy, right? Those things are common with the decline in estrogen. And so fortunately though, there's we can do something about that, right? This is one of the areas of modern medicine where we've made like tremendous progress, right? And this is exciting. We'll spend a lot of time discussing some of that stuff here in a few minutes, okay? Let's tackle the elephant in the room. Let's talk about hormone replacement therapy. All right? Or also sometimes it's called menopause hormone therapy, MHT, right? Not just HRT, but MHT, depending on which guideline you're reading, So there's few topics in women's health that have generated more confusion over the past 2 decades. I still hear, people operating on previous notions, or thinking about, managing the hormone situation using previous ideas and ways of thinking, right? But things have changed for sure. For some women, the words of hormone replacement therapy immediately trigger fear, right? Immediately. For others, it's viewed as, shoot, this could be an answer to every symptom I got, But the truth is probably, somewhere in the middle, I think to understand where we are today, we first have to understand how we got here, right? I think that's important. Back in the 80s, 1980s, it's funny. I was born in 1977. And one of my son's friends one day said, "Oh, you were born in the 1900s?" I thought that was great. Anyway, back in 1980s and 1990s, hormone replacement therapy was widely prescribed, right? Many clinicians believed estrogen offered benefits beyond symptom relief, right? They thought it could help with reduced cardiovascular disease and support long-term health, which they were right. But something happened. Something happened. The Women's Health Initiative, often referred to as the WHI. And so when the initial results of the WHI were released in 2002, headlines around the world, my gosh, they got a hold of this stuff sooner than the papers were even published, right? But these headlines just around the world suggested that hormone therapy increased the risk of invasive breast cancer, heart attacks, strokes, and even blood clots, right? And so those headlines spread so quick, so fast, almost overnight. Millions of women just flushed all their hormones, and many physicians became understandably cautious about prescribing them, and so for years, countless women who may have been able to benefit from hormone replacement therapy either never started it or discontinued it out of fear. And that is sad. But here's where the story becomes more interesting. As researchers continued analyzing the data, several important factors emerged. The average age of women, get, get this, the average age of women in the WHI in the studies were around 63 years old, right? 63. Many of the participants were more than a decade past starting menopause, right? And that matters. That's super important detail, right? Because cardiovascular systems of a woman who begins therapy close to menopause is not the same as that of a woman who started 10 years later. You know what I mean? Also, the formulation in the study also matters. So much of the attention centered around oral conjugated equine horse estrogens combined with medroxyprogesterone acetate, right? They were calling it progesterone, but it's not a progesterone. It's a progestin, a synthetic progestin, right? And so today, man, we have so many more options. We have so many more options, including transdermal estradiol and micronized progesterone. These are bioidentical hormone replacement therapy options, right? And each of these have different pharmacological properties. And so, I think even most important, I think researchers began looking at individual outcomes based on age, time since menopause, and route of administration, and really overall health rather than just treating all women as one group. You know what I mean? And so, in other words, the conversation started to becoming more personalized. And that's how healthcare should be. That's how it should be. I think that's one of the most beautiful things about science, right? Science isn't stubborn, guys. Science is self-correcting. As new evidence emerges, we refine our understanding of the things, right? That's not weakness. That's just the scientific method doing exactly what it's supposed to do. So if you hear, your healthcare provider say something like this, our understanding has changed. Well, that shouldn't decrease your confidence in that healthcare provider, right? It should really increase it, because it means they're willing to follow the evidence wherever it takes them, and that's good. That's a good thing. So what do our major professional organizations tell us today? This is really cool. So organizations like the North American Menopause Society, that's a good one. You can actually go to their website and they have all kinds of great information on their website. The Endocrine Society, and even the American College of Obstetricians and Gynecologists, they all emphasize individualized decision making, right? We're not just like a one size fits all approach, right? Individualized care. That's awesome. And so for many healthy women who are younger than 60 or within approximately 10 years of menopause hormone therapy can be hugely appropriate, right? It can be an awesome option for treating moderate to severe vasomotor symptoms, hot flashes, or improving quality of life just overall, and even helping bone mineral density. This is big, right? Now, I didn't say every woman should take hormones. Okay. Please don't think that I'm saying that. That's not what I'm saying. And I also didn't say that hormones aren't inherently dangerous either, right? I said the decision should be individualized for each person. All right. Let's talk about the timing hypothesis. I alluded to that here just a few minutes ago, but one concept that you'll often hear discussed is something called the timing hypothesis when talking about menopause. And so here's a simple version. Okay. So I'll tell you, here's a story, right? Imagine two women, right? The first one is 51 years old and she just entered menopause, right? And so the second woman is 74 years old and she's lived with significant estrogen exposure. She's lived without significant estrogen exposure for some time. Okay. And so should we expect those two women to respond identically to hormone therapy? Nah, probably not. Probably not. The timing hypothesis suggests that the effects of initiating hormone therapy may differ depending on when treatment begins relative to menopause, right? And so while this concept is, they're continually studying this stuff, right? But it's become a pretty important part of how clinicians like myself think about like cardiovascular risk and patient selection when, considering hormone replacement therapy. Again, the message is like timing matters, right? It definitely matters. Okay. So you may be wondering, what can systemic hormone therapy potentially improve? Right? What is okay. So if I decide to go down this rabbit hole and start estrogen therapy or estrogen progesterone, depending on, whether or not you have a uterus, uh, what is this going to help do? Right? Well, it can help with hot flashes. It can help with night sweats. It can help with sleep disruption related to night sweats, right? It can help with mood changes that are closely linked to those symptoms. It can help with vaginal dryness in some women, although not always completely. And we'll talk about vaginal estrogen here in a little bit. It can also help with painful intercourse related to estrogen deficiency in a lot of the times. It can help improve bone health, and it can just improve quality of life, period. Many women will also report improvements in energy levels, concentration, just overall just feeling better. And those experiences can vary, from person to person. But I mean, there's a lot of things that it can do to help. At the same time, it's super important to remember that hormones are not a cure all. Okay. Like if someone has untreated sleep apnea, or depression, or maybe they have thyroid disease, or just some other kind of medical condition, those issues also deserve attention, you know. And I did mention progesterone just a few minutes ago. Let's talk about that. So I think that progesterone doesn't always, it's not in the spotlight, right? It doesn't get the attention that it deserves a lot of the time, but it definitely is important. And so if a woman still has her uterus and she's prescribed estrogen therapy, she needs to be on progesterone. And it's generally recommended to help protect the endometrium or the inner lining of the uterus to become too thick, right? And in simple terms, estrogen encourages growth of the uterine lining, right? But progesterone helps to kind of push back against that. It helps to regulate that growth. Think of them as partners performing different jobs, right? And this is one reason why it's so important to not self-prescribe hormones, right? Or borrow somebody else's. My God, don't do that, right? Because the right treatment depends on the individual, right? It depends on their anatomy and their symptoms, and their medical history, right? And another point worth mentioning, I think, is that micronized progesterone and synthetic progestins are not the same. Remember earlier when I said that in the WHI, they were referring to medroxyprogesterone acetate as a progesterone, but it is not. It is a synthetic progestin, and those details matter, right? This is why you hear some people say them differently, right? Because they're not the same, right? Talking about routes of estrogen. This is important, right? Because there's a little nuance to this. This is not all estrogen reaches the body the same way. Okay. And so oral estrogen is absorbed through the GI tract, right? And it passes through the liver, and it does that before entering the body's circulation, right? And so that first pass, they call it the first pass effect. And so that first pass effect, metabolism, can influence clotting factors, right? It can also influence triglycerides and other liver mediated processes, right? And so transdermal estrogen or transdermal estradiol, whether delivered through a patch or a gel or a cream or a spray, it bypasses much of that first pass liver metabolism. I'm sorry, I'm getting a text message. Anyway, for some women, hmm, sorry about that. For some women, that difference may be clinically meaningful, right? So particularly when considering certain cardiovascular and thrombotic risk factors, right? If you have a higher risk for blood clots, this really matters, right? So transdermal estrogen would be the best option, right? That doesn't make one universally better than the other, but just considering this goes back to individualized care, right? It just simply means we have options, right? And that's cool. That's cool. I'd like to briefly address another question that I hear frequently. All right. And this is about testosterone, right? Can women take testosterone? The answer is sometimes. Sometimes they can. A lot of the times they can, really. But you got to be careful, right? Testosterone just isn't a male hormone, right? Women naturally produce testosterone as well. And although they do so in much smaller amounts. Okay. So for carefully selected women, particularly those with hypoactive sexual desire disorder, after other contributing factors have been assessed, I think testosterone therapy can be very, very much considered, right? However, it does require, really thoughtful dosing, really careful monitoring, and a clear discussion of benefits versus risks, uncertainties and potential side effects and stuff like that, right? It's not about creating high testosterone, right? There's a lot of things that can happen with women who are on progressively high levels of testosterone. And some of those things are not reversible and they're not good. But if you do it right, which I have lots of women who are on testosterone, and we do it right. We follow them very closely and we make sure that things are proceeding and progressing as they should. You know, I think this is one of the most important things that we should talk about today. And it's like hormones can't replace exercise, right? They can't replace healthy nutrition. They can't replace sleep and they can't replace resistance training and they can't replace meaningful relationships, and they can't replace like stress management. I tell patients sometimes hormones help create a healthier environment, but you still have to build the house. You know what I mean? It's if the foundation isn't there, yeesh, it's not going to work well, right? Hormones alone won't create lasting health. You know what I mean? And honestly, that's the good news, right? Because it means that you have more control over your future than you might have thought, right? So it's good news. It's good news. If you've ever been a patient at my clinic, and some of you have, you've probably heard me say something really similar. Like, I don't treat lab values, right? I treat people, right? Labs help guide us, right? Symptoms matter. Medical history matters. Risk factors matter. Goals matter. Preferences matter. Like, all these things matter. It's not just the labs, right? So every woman who walks through the door brings a unique story to the table, right? And that story, it deserves an individualized plan, right? And not a one size fits all protocol. And I hate to hear it, but some women feel that way when they come in after being seen by several other people, and so anyway. So where does that leave us, guys? Let me have a hormone therapy can be incredibly valuable. It can be an awesome tool, right? For the right woman at the right time, right? But one area that's so frequently overlooked, and I think one that deserves its own conversation, is a topic that women usually really hesitate to bring up, right? Even to their own healthcare provider, they don't like talking about this. And it's vaginal health. Like, I have to bring it up. It never comes up. And when I bring it up to some of my patients, they're like, yeah, I'm having that problem. But they would not have brought it up had I not brought it up. Ladies, you got to talk about this stuff. You got to tell your healthcare provider all the things because treatment plans will be variable. They'll vary from one thing to the other, right? And so this is important, right? Vaginal health is important. Urinary health is important. Pain with intimacy, you got to talk about those things. If you're having recurrent like urinary tract infections, you got to have conversations with your provider about this stuff. This is super, super important. Don't hold back. We're not going to get embarrassed and you shouldn't be embarrassed. The collection of all those symptoms is called genitourinary syndrome of menopause, also known as GSM. GSM. And I have to tell you, this may be one of the most life-changing conversations we have today for many of you women today listening. So let's talk about it. I've had women sit across from me in the clinic, lower their voice, look toward the floor and almost whisper, "Can I ask you something kind of embarrassing?" And my answer is always the same. Of course you can. Trust me, if you've experienced it, I promise you, you're not the only one. Other people have. Because I almost can guarantee that it's not going to embarrass me. It shouldn't embarrass you. I think I probably heard it all by now. I've been in healthcare for a very, very long time. So Let's change the language. Let's first. I'd like to retire an old phrase. Okay, for years these symptoms were referred to as vaginal atrophy. Now, I kind of understand why that terminology developed. Okay, I get it. But let's be honest, the word atrophy doesn't really exactly inspire a lot of hope. You know what I'm saying? Today, most experts use the term, like I said, genitourinary syndrome of menopause, right? I like that terminology a lot better. You know, it, it acknowledges that menopause affects much more than just the vagina, right? It also affects the vulva, the urethra, the bladder, the pelvic floor, the connective tissue that's surrounding all this stuff, and ultimately a woman's comfort, maybe even their confidence. Yeah, yeah, for sure. And definitely your quality of life. And so let's talk about why this is happening. All right, pay attention. This is really good. What's really happening? Remember earlier when we talked about estrogen receptors being just like everywhere, right? Well, the vagina, the vaginal tissues are rich in estrogen receptors. Okay. For decades, estrogen helped maintain healthy blood flow, collagen production, elasticity, thickness of the vaginal lining, lubrication, and that acidic environment that supports healthy microbiome, healthy urinary issues, urethral issues. As estrogen declines, though, those tissues start to change, right? And so I like to explain it like this. Imagine like a waterfall. No, no, let's do it again. Let's try again. Imagine imagine a beautiful garden. I'm sure you see where I'm going with this. So imagine a beautiful garden and you're watering this garden every day for 40 years, right? The flowers are vibrant, the soil's healthy, everything functions just exactly as it should. Then one day the water supply gradually decreases. Okay. Nothing dies overnight. All right. It doesn't work like that. Nothing dies overnight. But over time, the soil becomes drier, right? The plants become more fragile and things just simply don't function the way that they used to, right? Well, that's very similar to what estrogen deficiency does to the vaginal tissue, right? So you may be asking, like, what symptoms might somebody notice, right? So we talked about a few of them: vaginal dryness, burning. You can have some burning or some itching, right? You can definitely have pain during intercourse. You have less natural lubrication, right? And you can even have bleeding after intercourse because the tissue becomes really friable, right? You can experience urinary urgency where you just feel like you got to pee all the time, and you will also experience maybe more frequent urination. The burning that it feels kind of like a urinary tract infection, even when cultures are negative, right? And so, but then again, you can have recurrent urinary tract infections as well, right? And also feeling like intimacy has become something that's you want to avoid, instead of something to enjoy because it's painful, right? And so I want every woman listening to hear this. These symptoms are common. Okay. They're not something that you simply have to live with and you don't have to be embarrassed about talking about them. I encourage you to talk with your healthcare provider about them, right? It's super important because we can't do anything about it if we're not talking about it. And I'd also like to talk about something we don't measure with laboratory tests: relationships. I've cared for women who stopped initiating intimacy, not because they don't love their spouses, right? I've been talking a while. I'm starting to get a scratchy throat. They stopped initiating intimacy, but again, not because of their spouse, not because attraction disappeared, but because intimacy has become kind of painful, right? And then others began feeling guilty. Some feel embarrassed, right? And others wondered if something was wrong with them. Ladies, nothing's wrong with you. You're experiencing predictable biological changes, all right, that happen. And fortunately, we have options that can help with it. Okay. I'm going to recover here in a second. Just give me a second. Maybe I should play some music for a second. All right. You know what? Here's something that surprises many patients, but even women taking systemic hormones, they also some of them continue experiencing vaginal symptoms. Why? Well, because the amount of estrogen that's reaching those local tissues isn't always sufficient enough to completely reverse the changes that have occurred in that area, right? And that's why some women would really benefit from adding local vaginal estrogen. And so there's lots of different types of vaginal estrogen, right? And you can use vaginal estrogen even if you're using systemic hormone therapy. And that's perfectly reasonable to do. And there's a lot of people that are doing it. And I mean, it can make some dramatic changes. It can really, really change the game. It's probably, one of the most misunderstood therapies in all of menopause medicine. You know, a lot of women, when they hear the word estrogen, they automatically assume every estrogen product carries identical risks. That's not true. That's not how the pharmacology works, right? So low dose vaginal estrogen is designed to act primarily on the local tissues of the vagina and the lower urinary tract, right? And so this systemic absorption is much lower than with conventional systemic estrogen. And so its goal isn't to flood the body with estrogen, right? It's for the local area, right? And so what benefits do we commonly see is that we see healthier vaginal tissue, right? We see improved lubrication, less discomfort during intimacy. We see improved elasticity. We see lower vaginal pH, which is what we're looking for, right? We're seeing restoration of healthier vaginal microbiome, right? Reduced urgency in women, reduced frequency of recurrent urinary tract infections, like all the things we talked about. You see a lot of improvement with local vaginal estrogen. And, I mean, really, it just improves quality of life all around. I mean, it's a pretty impressive list of stuff that it does. I'd like to ask you guys, all of you, not guys, I'd like to ask you people who are listening a question. Imagine if every time you walked, it hurt, like every single day, right? Would that affect your mood? Yeah. Would that affect your relationships and your confidence or your desire to exercise, your overall happiness? Of course. Of course it would. Now imagine if something as personal as intimacy became consistently uncomfortable. Well, that doesn't just affect the body, right? It affects marriages. It can affect relationships, self-confidence. It can affect your emotional health overall. And that's why I believe like treating GSM, genitourinary symptoms of menopause, isn't simply about treating tissues, right? It's about restoring quality of life. And that is super, super duper important. Naturally, like one of the first questions that women will ask is vaginal estrogen safe? And for many women, the answer is absolutely it is, right? Because current evidence and guidance from menopause societies support the use of low dose vaginal estrogen for women who have GSM, because systemic absorption is minimal, but symptom relief can be like substantial. You know what I mean? Even if you have a history of breast cancer or you have like that BRCA gene that predisposes you for, increased risks of cancer, vaginal estrogen is such a low dose, it just doesn't go into the system. Like for instance, there's a vaginal ring called E-string. And I think it's called E-string. E-string, yeah, I think that's what it is. It's just a little disc or a little circular device that you insert around the cervix, and it contains 2 milligrams of estrogen fully. That's it, 2 milligrams, and it delivers about 7.5 micrograms of estrogen in the local space in a 24-hour period. And you just change that thing out every 90 days, and it's super simple, right? I mean, there's a lot of great options out there. That's just one example, but it does not affect or increase cancer rates, right? So anyway, that said, medicine's not a one size fits all, right? Every woman's medical history is different. We've talked about that, right? Some women, particularly those with estrogen sensitive cancers or other complex medical conditions, they should have individualized discussions with their oncologist first, and then their medical provider that's helping them through their menopausal symptoms. and they should coordinate that stuff together. Optimally, that would work really great. And so that's why those conversations shouldn't be had. That's why you got to talk about this stuff. I also want to mention something pretty important. If you're postmenopausal and you're experiencing vaginal bleeding, let's not dismiss that. Let's not simply assume it's from menopause, right? Because while many causes of vaginal bleeding in menopause are benign, postmenopausal bleeding always deserves evaluation. It always deserves a little bit more attention. Think of it this way. It's probably nothing serious, right? But it's important enough that you should not ignore it, right? So definitely bring that up. The next thing we're going to talk is pelvic floor, right? The pelvic floor. We're going to briefly talk about this and then we'll move on. Many women experience changes in pelvic floor function after childbirth, during aging, and throughout menopause, right? Sometimes symptoms like urinary leakage, pelvic pressure, or like discomfort, improve dramatically after pelvic floor physical therapy. And this is something that a lot of people don't even know that exists, right? Pelvic floor therapists perform incredible work, right? And it is truly helpful for so many people. And they're really one of those hidden gems of modern healthcare, right? So if you're concerned about your pelvic floor, there is pelvic floor physical therapists out there that can really guide you to improve that environment. So all you got to do is just look it up. Pelvic floor physical therapist, or just call a physical therapist and say, do you know somebody who does pelvic floor therapy? And chances are they do. Let's move on to the microbiome of the vagina, the vaginal microbiome. One area that is becoming increasingly interesting involves the vaginal microbiome. And so just like your gut has its own microbiome ecosystem, so does the vagina, right? Healthy estrogen levels help to maintain an acidic environment that favors a specific microbe called lactobacillus, right? And as estrogen declines, that microbial balance, it shifts, right? I can get into the nuts and bolts of that if you'd like quickly. So your vagina or your vaginal tissues have superficial cells where glycogen is deposited in, right? Estrogen stimulates glycogen deposition into the vaginal cell wall, the superficial layer, right? And lactobacillus feeds on that glycogen, right? And creates a healthy environment, right? A pH balance. And whenever your estrogen levels decline, that pH balance also it goes up. It becomes more alkaline. And that's no good because then that can create issues with infections, recurrent urinary tract infections. And so it's another reminder that menopause isn't simply about hormones. It's about an entire biological ecosystem, adapting to new environments. So ladies, if no one's ever asked you about your symptoms, allow me to be the first one. Okay. You deserve to have this conversation. You deserve to ask the questions. You deserve to know your options, right? And most importantly, you deserve to know that painful intimacy, like chronic dryness and recurrent infections or urinary discomfort, that's not a price of getting older, right? Those things can be helped, right? So you don't have to live with those things. All right. Okay. We're pushing an hour and 5 minutes, so I'm trying to get through this, but I just wanted, like I said in the beginning, there's so much stuff here I wanted to talk about real quick, but I didn't want to just glaze over it. And so thank you for being patient, and I hope you're enjoying the information. So we've talked about hormones. We talked about vaginal health. We talked about restoring comfort. Now let's zoom back out, right? Because even if we optimize hormones, even if we optimize vaginal health, right, there's still another major piece of the longevity puzzle. In fact, I would argue that it's probably one of the strongest predictors of how independently you'll live over the next 30 years. All right. Again, we're talking about muscle and strength and power. And we're also talking about what new research is teaching us about how, about how to protect both the body and the brain. Right. Let's head to the gym. What do you say? So let me ask you to do something with me. Close your eyes just for a moment. Well, okay, well, hang on. Well, not if you're driving. If you're driving, keep your eyes open, but just imagine yourself, if you're around my age, 50, just imagine yourself 30 years from now. All right. You're 80 years old, right? What do you want your life to look like at 80? All right. Do you want to travel? Maybe you want to play with your grandchildren, you know. Maybe you want to, like I do, carry your groceries into the house all at once, you know. I try to do that. Maybe you want to walk with your spouse on the beach, you know. Maybe you want to maybe you'll have great grandchildren at that time. You want to get down on the floor with your great grandchildren. And most importantly, like you want to get back up, without help, right? That's the person we're training for today. Not next summer. We're not training for next swimsuit season. We're not training for the next vacation, right? We're training for the life that we want to live decades from now. And this is an important nuance, right? I think one of the biggest mistakes that our culture makes is reducing exercise to just appearance. It's so much more than that. It is so much more. We've been conditioned to believe like exercise is primarily about losing weight, or fitting into smaller jeans, achieving a certain number on the scale, and those things can happen, right? They will happen if you're focusing on these things, but they're not the greatest gift that exercise gives us, right? The greatest gift is preserving freedom, right? Freedom to move, freedom to travel, right? Freedom to remain independent, not have to live in a nursing home, right? Freedom to live life on your terms. That's what exercising now is going to give you your future self, right? I've started explaining muscle a little differently to my patients, right? Think of muscle like a retirement account, okay? This sounds weird, but just go with me on this, okay? Every workout is a deposit, okay? Every year of inactivity is a withdrawal, all right? The problem is most people don't realize they're making withdrawals until the account is nearly empty, okay? And so, unlike your financial retirement, you can't suddenly decide at age 78 that you'd like the, you know, 30 years of deposits. That doesn't work that way, So, why don't you think that resistance training becoming even more important after menopause? There's several reasons. As estrogen declines, the body becomes less efficient at maintaining muscle mass. Also, muscle protein synthesis, it becomes less responsive. This is anabolic resistance here. Also, recovery often it changes. It's not the same, right? Bone health becomes increasingly dependent upon mechanical loading because you're not making the estrogen to help support a good bone environment, right? Also, insulin sensitivity becomes more important because you're losing lots of muscle, right? And so, with more muscle loss comes more insulin resistance, right? And so, falls become more dangerous. Everything points to the same conclusion. Strength becomes one of the greatest forms of preventive medicine available across the board. Across the board. This is why I talk about it so much. Let me tell you one of my favorite studies. So, researchers followed twins for approximately 10 years. All right. And what made this study fascinating was that the twins shared genetics and much of their early environment, right? And this allowed investigators to explore why differences emerged over time, right? And one of the strongest findings, women who demonstrated greater leg power at baseline tended to experience better preservation of cognitive function over the following decade. Think about that. Leg strength. My gosh. Leg strength predicts brain health. That is amazing. That is amazing. It's not because you like your quads, somehow store memory. That's not, but it's because healthy muscles and healthy blood vessels, healthy metabolism, and healthy brains all work together, right? It's another reminder that the body doesn't age one organ at a time. It ages in systems, right? And so let me tell you another story. All right. I like to tell you about two hypothetical women. Both are age 75. Okay. Both weigh 150 pounds. One spends days sitting. All right. She struggles to stand without using her hands, right? And so she stares, completely intimidating. Doesn't even like looking at stairs, right? She avoids carrying heavy objects, right? Because she's always worried about falling. And so the second woman, 150 pounds, right? She strength trains twice a week, just twice a week. She carries groceries. She gardens. She plays with her grandchildren, right? She confidently climbs stairs. right? On paper, they weigh the same. They're exactly the same on paper, right? But in reality, they're aging completely different. The scale just never tells us the whole story, you know? Their strength is the difference. So here's something that's changed the way that exercise scientists think, right? Strength is important, but so is power, right? So we're going to move from strength to power. This is important. This is just a little piece. Power is simply how quickly you can generate force, right? And so why does that matter? Imagine like you're on the edge of a curb, okay? And you have about a fraction of a second to catch yourself, right? That's not a strength test, right? That's a power test, right? Can your muscles respond quickly enough to power through, prevent that fall from happening? And so that's why movements like sit to stands, or step ups, stair climbing, are, of course, appropriately supervised, can be so valuable later in life, right? I think one thing else we should talk about, since we're talking about these performance, is balance, right? Many people think that balance disappears with age. It doesn't. It doesn't. It's a skill. And like almost every other skill, it just improves with practice. Check this out. So I was watching this video the other day on social media, and it was this guy. He looked like he was probably in his 80s. And he was like, I'm going to give you a version of a push up. And so he gets in the plank position and he does the push up. And then whenever he pushes back up, then he starts cocking his elbows out and he starts putting his knees on his elbows, if you can imagine that. And then all of a sudden, he pops his legs up and he pushes up to a standing, like a handstand. Then he lowers himself back down slowly and then falls back into a plank position, does the push up again, and does the handstand push up. I was blown away. I was blown away. This guy, he's definitely in his 80s, but he was doing things that I can't even do now. Like, it was really, really impressive. Age is not a limiting factor for most people, right? You just have to get started and be consistent. You can start with like just standing on one leg, brushing your teeth, you know, walking heel to toe, single leg exercises. You can do stuff, that's really, really going to help with that balance. Tai Chi is a good idea. So even certain forms of yoga, right? Those simple activities help train the nervous system, and it helps to train it so it can coordinate movement more efficiently. And you just got to do it repetitiously, right? And it will help, and you'll get better and better. And balance is awesome. It's really, really important. I think falls become later on like one of the leading causes of injuries in elderly adults, because they're not strong and they don't have balance. They haven't practiced those things. So let's move from the muscles to the engine that powers all of them. All right, let's talk about the heart real quick. If resistance training can help build the engine, aerobic exercise improves the fuel system. All right, so both matter, okay? One without the other leaves something else, off the table. And so it's super important. I like to do sprint interval training. And this goes back to that study at the beginning that we were talking about quickly. I've become like increasingly fascinated by the research involved with sprint interval training, right? And so I began myself doing sprint interval training a couple times a week. And let me tell you, it sucks. It is not easy. It is not easy, but you can build up to it, right? Let's define what we're talking about here. So sprint interval training doesn't necessarily mean running as fast as you can, like down a football field. That's not what that is. In research settings, it's more like sitting on a stationary bike, or a rowing machine or some type of other equipment where intensity can be, controlled really safely, right? And so the idea is really simple, right? Very short periods of hard effort, like 85 to 95% of your maximal heart rate, followed by longer periods of recovery. And so you repeat that several times. And here's what really caught my attention. Researchers have observed that this type of training can produce beneficial remodeling of the heart. Now, the word like remodeling, that might sound a little scary because cardiac remodeling can be a negative thing. It can be a bad thing. But this is cardiac remodeling in a good way, right? This is actually a very good thing. Think about your heart like it's upgrading itself, With appropriate training, it can become more efficient. Stroke volume improves, right? This means that your heart pumps more blood with each beat. As a result, your heart often doesn't need to beat as frequently and it will come down. Your resting heart rate will go down and it'll deliver the same amount of oxygen throughout the body. And that's pretty awesome. This is why you see athletes, that maybe are long distance runners, they have like baseline heart rate in the 40s or the 50s. Like it's crazy. But, they're just metabolically efficient. Their cardiac muscle is just really spitting it out there. Stroke volume really goes up with each beat. And so that's awesome. And it's not just, it's not just one, it's just not for athletes, right? You don't have to become a marathon runner, right? You don't have to train like an Olympian to see this change, right? You don't even need 2 hours in the gym every day, right? Small amounts of appropriately prescribed vigorous exercise can produce meaningful improvements and meaningful physiological adaptations. And that's incredibly empowering, especially for busy patients, instead for busy parents, right? Or busy professionals, or just anybody that says, Mike, I just don't have time to work out. It doesn't take a whole bunch of time. You can do a good one of these workouts in 20 or 30 minutes, to be honest. And so I do want to offer a word of caution. If you've been sedentary for years, today's probably not today's probably not the best time to go sprint up a hill. You know what I'm saying? Like it's going to take you got to build the foundation first, right? So you're going to want to start walking, then maybe start riding a bike or do, like stationary bike work, and then do some strength training, develop some consistency, and then gradually introduce higher intensity intervals that your body can adapt to, right? And so, longevity isn't about proving how tough you are today, right? It's about really just staying healthy long enough to keep exercising year after year and getting better. It's an investment, right? I'd like to leave you one final thought before we go into the peptide spotlight, and then we're wrapping it up today. Every workout that you complete today is a gift to your future self, right? You may not notice the benefit tomorrow, right? You may not notice a benefit next week, but one day, that version of you that's 75 or 85, will quietly thank you. It'll thank the version of you that's sitting here today because you made those deposits, right? You invested, you chose to prepare, right? And I think that's one of the most beautiful ideas in all of longevity medicine. It really is. So today we talked about hormones, vaginal health. We talked about muscles, bones, brains, hearts. Now let's shift gears to one of the most requested segments of this podcast. And it's time for another peptide spotlight. And so today's peptide is one that's generated like crazy interest over the past several years, right? Unfortunately, it's also generated a tremendous amount of misinformation. And so let's separate fact from fiction as we take a deep dive into PT 141. Okay. So, everybody, a lot of people that come into my clinic, they've already heard of PT 141 and they are actually specifically asking for it. But I have to go in, it's important because it's not a one size fits all. It's not like that silver bullet. You know what I mean? It's wild. I do love the story of PT 141. Okay, so let's talk about it. Sometimes the biggest discoveries happen in medicine by accident. And that's what happened with PT 141. Researchers were initially trying to develop a medication to improve sexual desire, right? And so they were studying a family of compounds called melanocortin peptides, right? And these peptides are involved in several physiological functions, including skin pigmentation, energy balance, appetite, and even aspects of sexual behavior, right? And so one of those compounds under investigation was melanotan 2. And so I don't know if you heard of that, but I've had several people in the clinic come in and ask me about that. And it was being explored primarily because of its effect on tanning and melanocortin receptors, right? But then something unexpected happened, right? Study participants began reporting spontaneous erections, right? Increased sexual arousal, and needless to say, the researchers got really interested. Sometimes science says like, hey, wait a minute, we weren't looking for that, But the scientists recognized that one portion of the melanotan molecule appeared responsible for these these effects on sexual function, And so through further research and refinement, they developed what eventually became bremelanotide, also known as PT-141. And today, it remains one of the most unique medications available for treating some forms of female sexual dysfunction because of where it works, not how it works, but where it works. And it's pretty cool. I can't emphasize this enough, right? PT-141 is not female Viagra. Okay. I hear that comparison all the damn time. I mean, it's catchy, it's simple, but it's misleading. It's not at all like it, right? Medications like Viagra and Cialis, they work primarily by enhancing nitric oxide production, and they help relax blood vessels, improving blood flow to the erectile tissue. That's how they work, right? They're working largely below the neck, right? But PT-141 works somewhere entirely different, right? It works above the neck, really. And, it acts primarily within the brain. And so I often tell patients something like this. It usually catches them off guard. The largest sexual organ in the body isn't found below the waist. It's the brain. It really is. Think about it. Sexual desire, it begins long before blood flow changes, right? It involves anticipation, it involves motivation and emotion, and reward, it involves like attention and connection and all those beautiful things, right? Like the brain orchestrates all of those processes, In PT-141, the way it works, it interacts with those melanocortin receptors, right? In the central nervous system, and particularly the MC4 receptors, melanocortin 4 receptors, which appear to influence the neural pathways involved in sexual desire and arousal. And so that alone is just fundamentally different mechanism than the medications we talked about, Viagra and Cialis. And so I like to explain it this way. It's imagine like you're trying to start your car, right? Viagra helps to, it helps to improve the fuel delivery system, right? Because of the vasodilation, right? But PT-141 helps to turn the key, right, in the ignition. And so those aren't exactly the same thing, right? So one helps the body respond, but the other helps to restore the motivation to respond, right? The libido, right? The desire, right? And that's the analogy. But I think it captures the difference, right? So who is PT-141 for? Well, this is interesting, right? The FDA approved medication sold under the name Vyleesi, 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 is approved for acquired, generalized, hypoactive sexual desire disorder in premenopausal women. Okay, so let's unpack that. Acquired means that the woman previously experienced satisfactory level of sexual desire, right? Generalized means that the reduced desire, it occurs across all situations. And what I mean by that, not just because of one partner, like one guy's a knucklehead, I'm tired of being around this guy. I don't want to touch this guy. It's all circumstances, right? And then hypoactive sexual desire disorder, or HSDD. It describes a persistent lack of sexual desire that causes personal distress, And so those distinctions are pretty important because, low desire can arise from many different, reasons, PT-141 isn't going to help with all those reasons. And so this is why it's important to have these conversations, right? Sexual desire is like incredibly complex. It's influenced by hormones, right? But also by our sleep, stress. When you're stressed out, it's hard to think about, sex, right? Also, relationship quality. That's super duper important. My gosh. Depression and anxiety. When people are depressed, they're not thinking about having a good time with their partner. You know what I mean? If they have chronic pain, or maybe even they have like low self esteem because they're not satisfied with their body image, you can really get caught up in your head about that stuff. You know, fatigue, and even like we were talking about vaginal discomfort. I mean, why would you want to put yourself through that, right? Guys, I hope you're paying attention. And there's just like countless other factors, right? And so when somebody says like my libido disappeared, my response isn't immediately, oh, well, here's a peptide, it's not, my response is, well, okay, well, let's figure out why. Let's talk about it. And it's kind of like a toolbox, right? This goes back to something we talked about through, this entire episode. I don't believe in magic bullets. I believe in toolboxes. I'm a guy, right? Imagine a woman comes in to the clinic. My mouth's getting dry. I've been talking a lot. Imagine a woman comes into the clinic with painful intercourse because of genitourinary symptom of menopause. Well, would PT-141 solve the pain? No, probably not. If intimacy hurts, increasing desire alone is not going to address the root problem. You know what I mean? And that's where local vaginal estrogen, lubricants, moisturizers, pelvic floor therapy, or even systemic hormone therapy, depending on the individual, may be more important. Now, imagine another woman whose tissues are healthy, her relationship is strong, her hormones are optimized, but who continues experiencing persistent, distressing loss of desire, sexual desire. Well, I mean, that's a very different clinical picture. All right. And different problems require different tools from the toolbox. Right. So how is PT-141 typically delivered? Well, it's an injection, right? It's, the FDA approved version is 1.75 milligrams of subcutaneously injected, you know, peptide. And you usually do that about 45 minutes before anticipated sexual activity. Okay. Some women notice effects sooner, some later, right? Clinical studies suggest that the response can vary quite significantly between individuals. And I've actually heard that from various patients in the clinic, right? And so, unlike medications that you take every day, PT-141 is generally just used as an as needed basis under the approved labeling, right? Again, before anticipated activity, preferably 45 minutes to 1 hour. Now, you'll know after the first time how it affects you, and then you can make adjustments thereafter. But I've had somebody tell me that it didn't take effect for 3 hours, right? But when it did, it was game on. You know what I mean? So you'll know after the first time. It's going to be about the same every time. So, what does the evidence show? Does it work? It does work. It does work. And clinical trials, though, I've seen it in my anecdotally, it works. And I think it works almost every time. But in clinical trials, excuse me, demonstrated modest but statistically significant better improvements in sexual desire. And so notice the words I use. It's modest, right? Not miraculous, right? It's not going to be dramatic for everybody, but it does work, and so some women experience really meaningful improvement. Others notice little benefit. And so managing expectations is part of practicing good medicine, if you ask me. And so a lot of guys ask me like, so well, can I take this? Well, you can take it. Some people will prescribe it off label for men, right? There's growing clinical interest, and there are actually some published studies that explores effects in men, which usually improves erectile function. So some people may prescribe it to you. It just depends. This is a case by case basis, and there are things that we need to talk about, right? There are some side effects, and there's some things that need to be addressed because some people should avoid it, right? It's not for everybody, right? The the FDA labeling advises against it in people who have uncontrolled hypertension, right, or just crazy high blood pressure that's not controlled, right, and that's known, or also people who have cardiovascular disease because PT-141 has like some transient cardiovascular effects, like I mentioned. And so this is why medications and peptides should never be viewed in isolation. And this is why people shouldn't buy peptides like online because you don't you don't know the risks, right? Most people aren't looking up the risks. They just hear what these peptides do. They're like, "Man, that's awesome. I can buy that online." But they don't have that conversation with the healthcare provider to kind of explain thoroughly what the risk could be. And so, anyway, I'd like to end today's peptide spotlight with a thought. If I can get through it without my voice going out completely. Sexual health is health. Okay. All right. It's not frivolous, it's not vain. It's not something that we should be embarrassed to discuss, right? We all have these lived experiences and we all are trying to figure this thing out. For many people, like sexual intimacy is an important part, right, of emotional connection. It's an important part of like self confidence, relationship satisfaction and just overall quality of life. And so when sexual dysfunction causes distress, it deserves some that same thoughtful, evidence-based approach that we would give any other health concern. You know what I mean? PT-141 is a tool in the toolbox, right? It's a really fascinating tool, right? But still, it's just a tool. Okay, there's lots of other things that may be going on, so you got to have the conversation. All right, so we're going to transition to a close. I've really enjoyed the conversation. These last little few minutes have been just wreaking havoc on my throat. So please excuse me. But we're gonna wrap it up here. So 3 things to remember, right? As we wrap up. Number 1, menopause is not the end of vitality. Okay? Menopause isn't a disease. Okay? It's not your body failing. It isn't the beginning of the end. You know what I mean? It's a completely normal biological transition. Normal doesn't mean insignificant. Okay. The hormonal environment that supported your body for decades has changed. Okay. That's it. Right. And because of that, your strategy has to change, you know? And so if you're experiencing symptoms, please don't assume suffering is a part of getting older. It's not, right? Ask questions, talk to your healthcare provider, have those conversations, seek evidence-based care, right? You deserve to understand what's happening inside your body. Number 2, we're going to talk about muscle real quick. Your muscles, it's one of the greatest longevity medicine that we have at our disposal. If there's one intervention that we've discussed today that benefits every organ system, it's movement, it's resistance training, right? Walking, cardiovascular fitness, balance, and power, right? These aren't simply just to burn calories, okay? They're just not just to make you look good, right? They're investments in your future dependence or independence, excuse me. And remember, don't train for the mirror, train for the memories, all right? Let me say that again. Don't train for the mirror. Train for the memories. All right. Train for the vacations that you're going to take in, 20 years from now. Right. Train for your grandchildren that you'll one day chase in the backyard. All right. Train for like the confidence of climbing stairs without being scared to death that you're going to fall. Right. Because one day your future self will thank you. Right. And in my opinion, that's one of the greatest returns on investment that you'll ever receive. Lastly, there is no single magic bullet. All right. Healthspan isn't built by one prescription. Okay. It's not built by one hormone or one peptide, or even a supplement, right? It's built by consistently making hundreds of small decisions that work together over time, right? Optimizing your sleep, building your muscle, protecting your heart, supporting your healthy relationships, maintaining sexual wellness, eating nutritious foods, managing stress, all that stuff, just super important. And when appropriate, working with your healthcare provider to determine like whether therapies like hormone replacement therapy and peptides belong in your individualized plan. And that's how longevity is built, one decision at a time. Anyway, I'd like to leave you with a final story. Like, last thing, imagine two women and they're celebrating their 80th birthdays, right? Neither knows exactly how many years they have left to live, right? None of us do, really, right? But one thing is different. One spent decades investing in her future, right? She lifted weights, she walked, right? She protected her sleep, she nursed her relationships. She sought help when symptoms appeared and didn't just silently accept them, right? She viewed menopause as not closing the door, but as the beginning of a different chapter, right? The others believed that decline was simply inevitable, you know, that that there wasn't much that she could do at all, that getting older meant just giving up, pieces of her life that she loved. Both women aged because aging is inevitable, right? But only one intentionally built her health span, right? And that's the difference, right? Not between aging and not aging. It's between aging intentionally and aging accidentally. And you know what? I know which one that I hope every listener out there becomes. All right. And that is it. I have really, really enjoyed you guys today. I really hope that you've enjoyed everything. Let's turn this down just a little bit. I'd like to finish, I'd like to wrap this up. I hope that this information has been helpful. If you have enjoyed today's episode, please consider sharing it with somebody who could benefit from this conversation. Maybe it's your wife, maybe it's your sister, maybe it's your mother or your daughter, or maybe it's a friend, who's quietly wondering why she doesn't feel like herself anymore. One conversation can really, really change a life. And as always, thank you for your time with me today. If you haven't already, be sure to subscribe so you never miss an episode of the Longevity Game podcast. Until next time, take care of yourselves, take care of each other, and keep playing the longevity game. Thanks, guys. Yeah, I hope you guys have a wonderful weekend. It's almost over, and we'll see you next week on the Longevity Game podcast.